go. All right, I'll say hello once again. This is Rebecca Imholtz with the Mount Pleasant Chamber of Commerce. I hope you're having a great day. It's absolutely beautiful, beautiful weather out there on this December 22nd, and hard to believe that Christmas is just a few days away. And I think as we get closer, though, the weather's going to remind us that it's December, because it sounds like it's going to be a very chilly day. And but enjoying today very much. A great day to get outside and do some Christmas shopping, and remember to shop local and support our local merchants. And John Carroll, how are you today? Are you ready for Christmas?
Doing very well, Rebecca, and that's not a topic we want to discuss right now. There are still days available to us, and I tend to work better under pressure at this time of year. So
very good.
But thank you for asking anyway. Thank you, Rebecca, and welcome everyone to The Pivot, a weekly series of informational discussions on our local, regional, and national issues in the midst of and following the current pandemic. This event is presented exclusively by the Mount Pleasant Chamber of Commerce. Thank you for taking the time with your chamber to join fellow members and staying informed to help you care for your team, your clients and customers, and of course, take care of business in post-pandemic conditions. As a service to the members of the Mount Pleasant Chamber of Commerce and the local community, we've been offering The Pivot weekly since the early days of the current pandemic. Our guest on today's edition of The Pivot is an executive with Roper St. Francis Healthcare, which has been on the front lines of treating those infected with the SARS-CoV-2 virus. As a key provider of community healthcare services, the system and its team members have faced challenge after challenge since March. We'll look today at how Roper St. Francis has been able to address patient, family, and community needs throughout the current pandemic. Our guest today on The Pivot is Dr. Chris McLean, Senior Vice President and Chief Physician Officer at Roper St. Francis Healthcare. Dr. McLean is board certified in internal medicine and is the Chief Medical Officer for Roper St. Francis. He received his medical degree from the Medical University of South Carolina, where he also completed his internship and residency. His specialties are internal medicine and primary care. Dr. McLean, welcome to The Pivot.
Thank you, John. I appreciate you having me. Pleasure to be here. And let me share your commitment to last minute shopping. I mean, I think that anyone can shop on December 10th. It takes real skill to do it after, say, the 21st. And so I've always enjoyed making that into a game and exhibiting my skill at late game shopping as well. So I appreciate to know I'm not alone. But seriously, I'll get into the presentation today. Is what's on everybody's mind is kind of the COVID event, and what my intention today was to share with you a little bit of our history with COVID-19, and then where we are today, and then as well give you a little insight into how we're managing it, as well as what we see coming with the vaccines and what you can hope to see maybe in the community as well. Let me share my screen here. So hopefully you can see the slides that I have there. Can you see that, John?
Yes.
Okay, so we'll get started. So, you know, at Roper St. Francis Healthcare, hopefully most of you know our system and are familiar with it. Our mission statement is something that we all know and we're all extremely committed to at Roper St. Francis, and that's healing all people with compassion, faith, and excellence. And it really does give you an idea of what's at the core of everything that we do, every intention that we have, and every perspective that we share as we move forward dealing with any disease. But certainly COVID has been no different to that. I'm Chris McLean, the Chief Physician Officer for the health system, and have served in a dyad role with Anthony Jackson overall operations for our health system. As you may be aware of from the newspapers back at the beginning of the year, Roper St. Francis went through a merger over this past calendar year with Bon Secours Mercy Health, who were minority owners in our system prior to that, and have joined more in a equal joint venture with Bon Secours Mercy Health, and it's been a great partnership so far. As we've brought healthcare. And so I always like to joke around and say that, you know, we're as the only nonprofit healthcare system that's private, we're here to serve Main Street, not Wall Street, and we grow by increasing value, not taxes. And so that's kind of my motto as we move forward, and the partnership's been great so far. So to talk a little bit about the timeline, most of you know this timeline, but as a refresher, In January of 2020, there was we've set up an informal infection prevention task force that really was looking at COVID-19 external to the United States and what we might see here. As February came into view, we put some more structure to that task force to prepare ourselves for what might be coming. And then, of course, in March, we know that we had the really ramped up, and we started seeing cases inside the United States and close to home. And then we had our first patient admitted to our ICU the middle of March. And by the end of that week, we had our command center stood up because that's when the governor came out and made some recommendations for the whole state. This is just a view inside of our command center where we run the bulk of the organization's response. And again, this is something we still have up today. All the information flows through this slide. You see myself there on the left and Craig Self on the right. Our interim CEO, Jim Berg, is there on the right too. Some interesting trivia. Jim was our interim CEO filling in this past year and also had a lot of experience with this type of thing as he was the CEO of the hospital in Dallas, Texas that encountered Ebola years ago, and so he brought that experience to us, and it was greatly valued. So this just gives you a view into how we track the COVID community amount in the community, and so this looks at our percent positive. And I would tell you this is a number that's thrown around in the media a lot of percentage of positive testing. There's a lot that goes into this percent positive, and so there's tons of testing that we do nowadays that are really screening tests that someone has no symptoms at all, but when we're doing at-risk procedures or procedures that may lead to a lot of aerosolization of respiratory secretions, then we test everybody coming into our hospital. We test everybody coming in for a procedure. And so that will skew, obviously, if you increase your number of tests you're doing, it skews the percent positive based on the number of patients that you're truly trying to diagnose. And so this is one that you see a lot. It's not a one that honestly we pay a lot of attention to until it gets up into the really high numbers like it did in July. One that's a lot more important for us is a rolling average of new cases. And so we will take a 7-day looking across 7 days, how many positive patients were in that 7 days and average it. And that's a much better reflection of disease prevalence and spread within the community. And it ties very closely into the inpatient census, which you see here. And the way that it ties closely is that there's about a 7 to 10 day lag behind seeing the disease prevalence kick up in the community and when we expect to start seeing those patients matriculate into the hospital. And that's been a pretty consistent metric of time lag through the course of this entire disease process. And so after this one doesn't go out as far, but if you looked at our experience over the Thanksgiving holiday, this is exactly what we saw once again, that once we had the holidays where we know people are cohorting together and maybe relaxing some of the social interventions, we see a predictable rise in the community that following week, and then we see a predictable rise in the hospital 7 to 10 days later. And that's been a fairly reproducible experience throughout the country and certainly in our area. So then we look at our risk factors and our patient groups. And so we've done this looking at the age group of prevalence of disease to try to understand where it's spreading and where we need to try to do some more interventions. We also look at the different demographic pieces to understand in our at-risk populations, or is there any type of health inequity that we can address and try to intervene on. And throughout the course of the entire pandemic, we've had these type charts going and this type of data analysis going to try to see how do we get in the community and kind of impact this disease where it's spreading. What's been interesting is that we've seen that, our cases seem to follow the typical risk profiles that you've seen across the country and you've heard about with respect to what other comorbidities seem to put people at risk. And so what we've seen is that the same type of experience. This gives you a good idea of what really has been a critical issue with this disease, and that's testing. And so this gives you an idea of all of the different timelines of when we developed the testing and all the different types of platforms that we've had to deploy. The testing has been a critical resource that until really about mid-year, we started turning the corner on what we had and what was available. And through diversification of supply chain, we've actually been able to kind of stay in front of it with respect to testing. And now we have antigen testing that we deploy in all of our emergency rooms. It's expanding out to our express cares, and we also have point of care PCR testing, which is a little more reliable, a little more sensitive and specific. And it's important to understand that too, and I would encourage your membership that if they are getting a test, to understand what type of test they're getting. The most reliable is a PCR test. That's not always the most available. Most of the ones that you see that are readily available for rapid resulting are antigen tests, and there's variability with respect to the sensitivity of those antigen tests. The one we're using, the Sophia antigen test, has really been head and shoulders above some of its competition out in the testing world, and so that's why we've chosen that platform and rely on that pretty heavily within the workings of our health system. This is not intended to give you anything other than a view into the complexity of dealing with patients with COVID-19. And so I'm not intending for you to understand this chart, but just to kind of let you see this is how we have to go through these type algorithms whenever we're navigating patients into our hospital, how to test them, what tests to use, how to put them in isolation if they need that, and how long do we keep them in isolation. So it's a very complex degree of things we have to think about and in order to navigate patients through our system without risk. And I'll tell you, to go back to this, one of the reasons we've been so successful in our hospital system at containing this disease inside our walls is because of the complexity of this and our adherence to it. So it's a very complex thing to keep this disease controlled and contained within your health system. And we've done that very well and had a very minimal amount of spread within our hospital. The treatments that are currently available really hasn't changed that much in the last few months. There's an antiviral medication, remdesivir, which is widely used. The results are, I would say, mild as far as what the outcomes are. The glucocorticoids, these are steroids. Dexamethasone is the most common one used. And that's probably, of all of the treatments that we've seen, the dexamethasone and the blood thinners or the anticoagulation have probably had the most effect with respect to outcomes. The anticoagulation is necessary because early on in this disease, we noticed that blood clotting is a significant problem, whether it was blood clots that then go to the lung or blood clots in the arteries leading to the heart. It was a significant problem that once we recognized that as a medical community across the country, recommendations were put out for anticoagulation or blood thinners to be used, and that's been very successful. There's also antibody-rich plasma, which you've heard about folks donating and being used in certain cases. I'd tell you that the data on that is inconclusive at this point. It's still being used in some cases, but it does not have a lot of data behind it to show the real impressive outcomes. Things that aren't currently used that were in the beginning, chloroquine and hydroxychloroquine, as well as azithromycin. There were some very small case studies that came out of Europe early on in the disease process, or in our understanding of the disease, which indicated these might be of help. They started to be used, and then we noticed they were likely harming folks more than helping them. And so that now is not only not being done, it's actually recommended against. The most recent therapy is one that's being implemented as an outpatient, and that's monoclonal antibody infusion. So it's basically reproducing the antibody to the spike protein and infusing that into high-risk patients to try to keep the disease and the viral replication under control. Again, I would tell you the outcomes for this have been very small, and they look somewhat promising, but not overwhelmingly so. So this is being used, but it's being used in very select cases. We do have both versions in our health system that we're infusing for high-risk folks that meet the criteria. Nothing can be said that is better than prevention. And so, you know, of all of those interventions we just talked about, by far and away the most impactful is prevention, and that's the things you've been hearing about all year: social distancing, hand washing, wearing a mask, A lot of debate in the community and out in politics and everywhere else about masking. What I can tell you is the data doesn't lie on that. We've got a lot of good data for wearing a mask and face covering, and that is very protective. And I think it should be, it should be adhered to if we're trying to impact the disease spread. Face shields are important, especially in high-risk areas. So if you're dealing with patients, certainly, but then also other areas where you're in close contact with folks that don't have masks on. Face shields are very important because you can transmit this disease through the mucosa of the eye, and so protecting your eyes is very important. Symptom awareness is critical. It goes back to the idea of testing and having the availability of testing to understand if you have disease. So being acutely aware of symptoms and even the minimal amount of the symptoms that can be present with infection, especially in the younger population, is very important, so that symptoms aren't overlooked and someone can be aware of their illness so that they can then quarantine themselves and prevent the spread to others. That gets into hypervigilance with testing and quarantining. This is critical if we're going to be able to continue to control this before the entire population gets vaccinated. Avoiding high-risk environments. I put this on here because this is something that our system learned very quickly, is that areas where you're eating around one another for whatever reason happen to be extremely high-risk environments for spread of this disease. And that's been seen not only in health systems, but in workplaces as well as in schools, where we know that lunch areas and break areas tend to be areas you really have to pay a lot of attention to and make sure you're distanced properly in those environments. So probably the thing that everybody wants to talk about the most is vaccine development. We do have vaccines that have been released, and we have other vaccines that are still under development and testing. There's been 11 promising vaccines that are currently in development and testing, or the 2 that have been released. The Pfizer vaccine has been the first to get emergency use authorization, as well now as the Moderna vaccine. These are now novel platform type vaccines, meaning that this will be the first time this type of vaccine has been widely distributed. It is not the first vaccine that's ever been made with this technology. It's basically messenger RNA technology, which means that is the code that goes into the cell to produce the protein that the body then mounts a response to. Typical vaccines and older vaccines would either give you an attenuated virus or just give you the protein from the virus, and then your body would mount a response to that protein. What this technology does is it actually gives you the preceding code that goes to the development or the production of that protein. It gives you that code into your own body's muscle cell. The muscle cell then produces the protein, and then your body mounts a response to the protein that your own cell produced. And the reason we think that's better efficacy is that the production of the protein is much more stable. There's a lot that goes into protein, the proper folding and the proper formation of these proteins, and it can be affected pretty significantly with an injection. And so this technology just gives you your body visibility to the native protein that's being immunized against. And so we think they're much more effective that way. They're also much easier to produce. So messenger RNA vaccines have a much quicker production timeline, and so it makes it obviously much easier to produce on a global scale. So these are the top 6 vaccines that are out there. The Pfizer was released in December, as well as the Moderna. Pfizer was the first one. It is the messenger RNA. We believe there's about 100 million doses that are going to be available. They've been ordered for the United States population, as well as the Moderna. I think that number has doubled now for the Moderna, up to 200 million. So the combination of those two, we're expecting about 300 million doses from those 2 supply chains to hit the U.S. markets. These other vaccines are different types of vaccines. So the Johnson & Johnson and AstraZeneca are both adenovirus, which means that instead of injecting directly the messenger RNA, that messenger RNA is actually in a virus itself that then uses that virus to inject into the cells. So it's just a different way of delivering the same type of technology of the messenger RNA. And then the Novavax and the Sanofi products are more of the typical older type of technology with respect to vaccines, where it's a protein itself that gets injected in the body's response to. So a little bit more about the Pfizer vaccine. This was the first one to come out a couple weeks ago. It's a 2-dose series. There's 21 days between the 2 doses. It's a very small injection, so it's a 0.3 cc injection. Side effects are very similar to what you've seen with other vaccines, and so the side effects really are there because of the body's immune response. And so the headache, the fatigue, the injection site pain that you have, sometimes some fever and some chills, are pretty self-limited. They last anywhere from 12 to 24 hours, and they're really associated with the body's immune response getting ramped up. And so these are the same type symptoms that you have sometimes when you're fighting acute illness, and so it is important to understand you may have these side effects right after you get the vaccine. They should be fairly limited with respect to their duration. If you have symptoms that last longer than that 24, 48 hour time period, you would think about actual infection that could be driving that, and so you'd want to get evaluated. But I would tell you, by far and away, the side effects that we've seen are seem to be consistent with what we expected, and haven't had any red flags associated with that. The vaccine is under production right now. Like I said, it's a very easy to produce and distribute. So the problem with the Pfizer vaccine has been one for storage. So these messenger RNA strands are actually encapsulated in a fatty type substance, a lipid substance, which in the Pfizer vaccine is what requires it to have such ultra cold storage. And this has been a problem that's limited distribution to more of the retail areas and other places in the community, because you really have to have these ultra cold freezers in order to be able to handle that. Most of the health systems have these for other utility and lab and places like that, and pharmacy storage. And so we have those. Certainly Roper has it and has been able to handle the vaccine and appropriately distribute it to our vaccination sites. The Moderna vaccine, again, same technology. The lipid coating is a little bit different in the Moderna vaccine, but it's the same principle that it is encapsulating around the messenger RNA. But the storage on this one is a little less frigid, so that because the lipid profile on it is a little more durable. So this one you can store at -20 degrees instead of having the ultra cold storage, which makes distribution of this one a little bit easier, because that's more consistent with commercially available freezers, and so it allows some improvement in logistics there. Again, same side effect profile. We do expect maybe a little more production of the Moderna than we originally expected, and so that's been encouraging news. And this one actually comes ready to dose, and you don't have to reconstitute it like you do the Pfizer vaccine. The Johnson & Johnson, as I mentioned, this is an adenovirus platform, and so basically it uses a harmless virus to actually inject the messenger RNA into the cells and kind of result in the same immune response. This is a 1 dose that's, again, being tested. It's in phase 3 currently, and probably in the first of the year will be put up for emergency use authorization. And the AstraZeneca is the same technology, but uses 2 doses, one, the initial dose, and then the second dose to get a better immune response. The efficacy of these 4 vaccines, I'll cover the first 2. The Pfizer and the Moderna have about a 95% efficacy to prevent significant disease. And so what that means is, it doesn't mean that there's absolutely no infection. What it means is the infection, because infection really is predicated by, did the virus meet your respiratory pathway? So did you get active virus in your respiratory canals? And if that happens, well, then you have infection. But what the vaccines do is rev up the immune response so that your immune response is immediate when you get that infection, and it doesn't actually progress to disease. It's important to understand that, because when you have these vaccines, it doesn't mean that you're immune to the point of never having to be preventative or to be aware of your surroundings or around high-risk folks that haven't had the vaccine yet, because theoretically it is possible for someone, even after a vaccination, to spread that virus to someone else. I would tell you that the data on that is being looked at in these trials, and we don't have any firm feeling on that yet, but it is theoretical at this point that you could still be a transfer vector to other people that are at risk that haven't been vaccinated yet. The efficacy on the adenoviruses aren't quite as good as the first two. We think it's around 60 to 70%, which is still a phenomenal response when you think about our past experience with vaccines, especially in viruses. And so that based on our older technology, that would be what you would expect, about a 70% efficacy rate. But certainly the messenger RNA, the first two, Moderna and Pfizer, seem to be more efficacious and getting a little more effect than the adenovirus vectors. So that's about it. I'm happy to answer any questions or cover anything else, John. If you know other questions have come up, I'm happy to answer anything else may have come up.
Dr. McLean, thanks so much for the boy. That was a crash course, wasn't it, on where we've been, where we're going, and how we got here and how we're getting there. So many items in there that raise questions, but the points that you made, I thought that were particularly valuable, included the fact that having gotten the vaccine doesn't mean that you can stop doing the things that are preventative, because you could still spread even as a vaccinated person.
That's right. And I think that's going to be really important to understand in the early months of the vaccination process. So, if you say, think about what do we expect? I expect this vaccine to continue to be distributed and all the other, maybe the two other leading vaccines to get distributed as well. And so over the course of the next 6 months, we're going to have vaccination kind of ramping up in all the communities across the country. But prior to that time, there's a lot of time that a lot of at-risk people can be subjected to this virus, and it would just be a shame if we had everybody relax and kind of think that, oh, the vaccine's here, we really don't have to pay attention anymore, we don't have to mask, we don't have to use the social interventions which we've seen to be so valuable. If people relax, then I'm really worried of what could come out from that. But certainly there's hope. Certainly these vaccines show promise, and I really do feel like we're going to get to the other side of this. We just have to be vigilant until we get there.
Dr. McLean, as we speak, we're just a few days away from the Christmas holiday, and of course, New Year's right around the corner. And those, at least in our culture, have traditionally been, holidays of gathering of family and loved ones, close friends, what have you. And many of those things won't be happening this year because of the virus. What would you suggest to those who are cautiously proceeding with their plans to gather?
So, it's a mixed bag. What I would tell you is, if we can avoid those high risk environments like we talked about, really be thoughtful about how you eat around each other. That seems to be such a high risk time frame for contracting the virus and transmitting the virus. So be real thoughtful about that, spacing and distancing when eating. And so when possible, eat outdoors, because it's a lot easier to spread out. I know in certain areas of the country that's been hard because it's been pretty frigid and snowing up north. But in our community, I mean, it's beautiful outside today. So put on an extra jacket and try to have everything outside. The other thing I think is really important is if you think about the experience we've had in the hospital systems, and this goes for all of our hospital systems, because I think we're all doing a good job of that. But I know we have, because I know our data. We know how to protect each other. We know how to keep it from being spread from a patient who we know has the disease to all the people that are working on that patient in the hospital. And it's just by protective equipment and how I would say that translates into the community and into your homes, and what I would even argue into our schools, into our workplaces, is we have to take that same thought process about how do I protect myself, how do I protect my teammates or my coworkers or my students, and you do it by wearing masks. You do it by washing your hands. You do it by remaining distant. I mean, there's so much that we know about this disease now compared to when we started, and we really do have the tools we need to control this. We just have to be vigilant to the process. And I think as we hear the vaccine coming out, there's a real risk that we could let down our guard. Everyone's exhausted. No one's more exhausted about dealing with COVID-19 than I am. I can promise you, everybody's exhausted about it. But we have to stay vigilant. It's like I equate everything to sports, and so it's like driving all the way down the field, and taking 12 minutes to get down the field. You get to the 5-yard line, and then you relax and don't get it into the end zone. Nobody likes that experience. And so what I'm asking is let's keep our eyes on the ball. Let's stay focused, execute properly, and get it in the end zone. And stay vigilant as we're right up here with the vaccinations coming out.
Wow, 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 wow. So many questions. Dr. McLean, now that the vaccine has started to arrive, and you've mentioned that you've started into vaccinating people. Talk a little bit about what the who's chosen to go first. You've got people obviously that are at risk. You've got team members that you want to make sure they can stay healthy because you protect your team members at Roper St. Francis. My father-in-law asked me yesterday, he's 90 years old. He's in pretty good health, but he said, so when do you think it'll be my turn? I didn't know what to tell him. What thoughts do you have on that?
Yeah, I think the question really around that is what's the supply chain going to look like in the next month? And my expectation would be is that, at least from the way it's gone so far, the group 1A, which has been the folks that live in long-term care facilities, they were in that first group to get vaccinated, and then healthcare workers. And the thought process behind that is not, necessarily a value equation per se, but it's when you think back to when we had our surge here in Charleston, the biggest thing that held us back from being able to treat this disease and treat the community the way we would desire is the scarcity of our resource of staffing. And so it became a significant issue in every health system. We were on, combined calls across the low country with all the other hospital systems, and we all shared the same exact experience that our teammates were getting affected by this. The global or the national levels of healthcare staffing made it very difficult because we were losing some of the opportunity of some of the traveling healthcare staff that we sometimes reach out to. We're going to other areas. And so the biggest issue around caring for this disease and the way we know we can is staffing. And so then, so that's why you see that the health systems have had kind of in that first category of classification for the vaccination. Then I think what you're going to see is it go out to the next level of at risk. And so those are areas where, officials or workplaces that have essential workers and that for the functioning of our community. And then I think you're going to very quickly see high risk, community members as well start to get this. So trying to get the vaccine to the folks that are at the greatest risk from day one has been our focus. And I know that the focus of the state DHEC health agency as well.
And so your point then, it really just begs the point of, the patience with which we take care of ourselves until the time, right? Not only up until we've been able to become vaccinated, but through that time as well, until we get to that term we heard way back when of herd immunity, right?
Absolutely, and I think there are a couple key points on that on the timing. Number one is, when are we going to get the vaccine for the community? And I think anybody's guess is, it's going to be most likely first quarter and to start, and then everybody's kind of projecting, by summertime we should have kind of rounded the corner with respect to getting to that herd immunity status. But it's important to understand that most of these two-shot vaccines that, it's about 4 weeks before we see the full immunity. So just because you get the shot on day one doesn't mean you're immune day two. It obviously definitively doesn't indicate that really the immunity takes at least a couple weeks to start revving up. And then when there's a second dose needed, again, another a week after that second dose usually. So we're talking about 4 or 5 weeks before you really, sigh a deep breath of relief and for yourself. And then again, keeping in mind that you could still be a vector to others at risk who haven't been vaccinated. And so I would say the protective kind of mindset and vigilance is really going to be most likely required into the third quarter of this year. And then depending on how the supply chain goes, maybe even to the end of the year. I think the fortunate thing is that a lot of the things we're doing for this virus apply to other viruses too. So it's going to be interesting to see how flu season is affected by our social interventions this year as well. And maybe some of that behavior carries on, for the next few years, that we actually see decrease in overall morbidity associated with the flu seasons as well. I would love to see that as a pleasant side effect of this whole experience.
So you are anticipating that there will be some permanent behavior change with people once they've gotten a little more educated on how all these things work and how they can.
I think so. I do. I do a lot of mission work and travel around the world doing mission trips. And one of the things I noticed last summer when I was in Burma, we flew into Singapore, and it was notable in Singapore the amount of people that were wearing masks in public places. And so I mentioned that because, COVID wasn't even on the landscape then. It hadn't come out yet. That was in response to the original SARS experience that Singapore had years and years ago. So I think it's 7 years prior, and you still saw some of that behavior modification in that population. And so I think we're going to see some of that here. I'm not sure it certainly won't be to the extent that you see it today. But I do think this type of awareness and education as far as viral transmission is going to have a lasting effect.
Dr. McLean, you also mentioned having gotten together with the other medical professionals in town. And of course, there's an ongoing friendly competition among healthcare systems, right? But I think there's been a level that you've gotten to in your work collaborating with the other systems. Talk about that a little bit.
Oh, sure. I mean, I think when, we set out at the very onset of this disease, understanding that we were a piece of the pie with respect to the community resources for healthcare. And so no matter what your size of that pie is, you're just one of the options and one of the things that we can use in a crisis like this. And it's really important to work in tandem with other systems because, number one, you want messaging to be the same. So you want to make sure that the community is not getting different messages. And so we were, tried to collaborate around that. We also wanted to collaborate around resources because, again, we were all kind of experiencing the same thing and wanted to understand, is there a resource that I had that they needed and vice versa. And so there was opportunity there. We were extremely transparent through the entire course of this pandemic as far as with the media and understanding, how many patients we had in our hospital, what experience we were having from a quality standpoint. Some of our outcomes were twice as good as what the nation was viewing. And so we wanted to share those things. If we were having experiences, that was leading to better outcomes in our system, I certainly want to share that with all of my colleagues across the community so that we're all on the same page and really treating people as well as we can. I mean, the bottom line is, again, I go back to our mission statement. I mean, it's healing all people with compassion, faith, and excellence. And that goes to collaborating with other systems as well, because it's for the betterment of the community itself.
Yes, indeed. Dr. McLean, I'm going to invite you to unshare your screen and let's invite Rebecca in here. She generally, after listening along, has a great question and might have one for us here.
Thank you, John. I actually have a question from an attendee, and then I have a question myself, but I'll start with the attendee's question. How long does the effect of the immunity last? 45 days? Any idea yet?
So that's a great question, and we don't have any great idea yet. We're still, carrying those. We do think it's been durable so far, and so I'll put it that way. So some of these, we start looking at it at roughly 4 weeks when the studies started comparing infection rates, and so far we haven't seen a tremendous lack of immunity as we carry those studies out. But a lot of that work has to be done months and months and, after your window of reflection. And so we won't know that probably until later in the year, probably third quarter, we'll start getting an idea of how effective really was this vaccine and how durable is the spike protein. So it's important when I mention that these vaccines are kind of targeting the spike protein, because we think that is a fairly durable protein of this virus. And the reason that's important, unlike some of the antigens and the proteins that the flu virus is targeted with the flu vaccine, the reason the flu vaccines have to be changed every year is because there's a lot of variability in those proteins from year to year due to genetic drift and some modifications and to the genetic structure. And so with the spike protein, even with some of the things that we've seen in the strains in Europe and South Africa, we think that the vaccine that's currently being developed is actually still viable against that protein, even in those strains. And so that's good news, because that kind of lends you to having greater durability of the vaccines.
And my question is, when you mentioned using a plastic face shield when you're in an environment where, I always have a mask on, but if you're in an environment where there are people that aren't masked and you feel like, oh, I could use some extra protection, I have this that I own.
Yeah.
That goes, yes. And then I've seen the ones that are kind of go around your neck. So do you have a comment on which one is best? Or are they both helpful?
You know, from that standpoint, it's probably a comfort in how you're moving in the mask, or in the shield. The limitation with the ones that go around the bottom of the neck I've seen is that if you turn your head like this, you can actually be, you know, no longer protected behind the shield. And so you just have to be careful with how you're using it. But I think either one of them, as long as it's giving you a shield in front of the mucosal surface of your eyes, that's really what makes the difference. And so, you know, so I do think, again, not necessary probably in the run-of-the-mill, you know, out in the community, but if you know you're going to be, you know, in close contact with somebody, and you know there's a high likelihood of secretions or droplet formation, you know, from the other folks, that's when those are a little more important. And so again, obviously in a healthcare scenario, you know, those are much more important.
Have any comment on the new strain that we're starting to hear about through the media coming from Europe?
Yeah, that's what I was alluding to before. When you hear about new strains, there's a couple things you really worry about. Did it affect, is there a mutation that's affected the transmissibility? And then is there a mutation that affects the immutability? And so when the immune response. And so in the transmissibility, it certainly sounds like maybe there has been some drift that's affected the transmissibility, for at least and again, I'll put the caveat out that all the data on this is very new, and we need a lot more experience and data. That kind of goes, that's our standing statement with all COVID. But what we see is that there might be an increase in transmissibility with this newer strain or drift. But the immune response seems to be still significant. So I think that we haven't seen anything that makes us think, okay, this is going to require some different way of immunizing. At least right now, it looks like these new strains are still susceptible to the same immune response that the original.
Thank you for talking about that again. I should have paid more attention in biology class, is what I'm thinking now. Didn't know it was going to come in so handy.
I think
Yeah,
we're all thinking we should have been to all those lab sessions instead of skipping out some of the lab sessions. Very well put, Rebecca. Dr. McLean, two more, if you don't mind. And thank you for your gracious and patient time with us. We ask a lot of people to, when they come on the pivot, to talk about the things that they've adopted that probably will stick, that probably will stay with them in terms of how they approach whatever it is that they do. What do you see that maybe you've done differently at Roper St. Francis that will become part of the everyday?
Oh, numerous things, you know, all the way from how we handle supply chain, you know, all the way up to how do we triage a patient, and what do we do for preparation to having surgery. You know, I think what's really helped us in this event is that we've become very agile at learning. And so, you know, it kind of sounds odd maybe for a physician to say that, but because we're dedicate ourselves to learning, but really you have to, it's a new process to actually be able to, you know, hear data, hear responses, get a consensus group together, respond to what you're hearing, get a collective idea behind it, and then put it into action in your health system or in your business. And that's a skill that has to be, you know, fine-tuned. It has to be managed. It has to be implemented intentionally. Otherwise, what you end up doing is either it gets past you and you're not responding quick enough, or you look back and you've made a lot of mistakes in the way, and you realize you have to course correct. And so we've become very adept in that. And that's something I think no matter what we face in the future, we're going to be able to take those same skill sets that we've refined by necessity and actually use them to other areas of our organization and operations. And we've already seen that, you know, kind of carry over into other things. We've adopted some of those same processes for handling completely non-COVID related incidences this year and been very successful with it.
Thanks, Doctor. And the last one, and this goes a little bit different direction, but you're working around an awful lot of heroes these days. And so if you would, and I don't mean to limit it to one, but if you have one or maybe two good examples in story form of people who have really stepped up and gone above and beyond in Roper St. Francis and your response to the pandemic?
Yeah. I mean, I won't use any names because I didn't ask them if I could divulge any names ahead of time. So in privacy, I'll reserve that. But I will tell you about a couple. And again, this wasn't rehearsed; it's just off the cuff here. But one is the head of our environmental services is just an absolute hero. And because when this disease first hit us, we had to respond by coordinating it off and cohorting these patients all together into these COVID units, which you may have read about and heard us talk about at different times. But so the head of our environmental services decided, this thing was so new and so scary. He said, I'm going to go in and I'm personally going to clean every one of these rooms. That until we know more, I'm not having my staff do it. I'm not having anybody else do it. I'm going to go in there myself and actually do the work myself. And to me, that's true servant leadership. I mean, that's leadership that says, I'm not going to ask you to do it. I'm going to show you how to do it. And that's an impressive thing, especially early on in this disease. And this is somebody who has a little bit of risk himself. So, I mean, he wasn't the type of person where I said, oh, he's definitely low risk category, so he was putting his own, health right out there in front of everybody and saying, look, I don't mean more to me than you guys mean to me. And to me, that spoke volumes with respect to his leadership style. And then I would say the other part is collectively, I would say, rather than talk about one particular person. I mean, I could say there's an ICU nurse that I know that really went above and beyond. There's an ICU attending that did, but really the collaborative effort of everyone who was involved, especially in the early months of dealing with this disease. I can't emphasize enough the amount of attention to detail and collaboration that was needed. Not just, we talked about a little bit with other health systems, but in our health system itself, having, all of the specialties around the table and, just really diving into what we knew about this disease and trying to get better understanding, trying to get better protocols, trying to get better at how we manage these patients and navigate these patients. It was such a team effort that it made me so proud to be associated with this health system, because it's not something that you see everywhere. And it really was, it went to speak to that, again, that mission statement. Everyone was putting that in the forefront of what we were trying to do. That you check your pride at the door, you checked your presuppositions at the door, and you came in and you just did what was best for the patient. And that was really humbling to watch and to be able to participate in.
Dr. McLean, you've been, again, so gracious with us, answering so many questions before we even had to ask them, and then the questions afterwards. If you would, please leave us with a final thought and where people can find out what they need to know about Roper St. Francis Healthcare. Absolutely.
I think the main thing that I would leave you with is about our system, hopefully from the insight behind the curtain, so to speak, on some of these things that we talked about today. You can tell the type of deliberate, intentional, effort that we've put towards this disease. And it's the same thing that we put towards every bit of your healthcare needs that you have. And so, this type of excellence in action is really what I think separates us out, amongst the crowd. And then also it would be, finally, I'll just end with, kind of a plea back to what we talked about numerous times is, please stay vigilant. Please understand this is very real. It's still going on. I know that we're getting to the end and you feel like there's a vaccine coming, and I'll be the first to tell you there is absolutely hope is on the way, that we will get to the other side of this. There's no doubt in my mind, but we've got to stay vigilant while we're in this home stretch, because there's a lot riding on it. This can, the effect and lasting effect of this disease can be dramatically different over the coming 6 months. And I think we have to stay vigilant, knowing that the help is there. These vaccines are amazing. There should be no hesitancy to getting these vaccines. The side effect profiles have been, what we expected. The efficacy of these vaccines has been better than we expected. And so I truly think help is on the way. We just have to stay vigilant until we can get it.
Thank you so much. And Rebecca will put up for us, I think, where everybody can find Roper St. Francis online. Dr. McLean, thank you again. Dr. Chris McLean, Senior Vice President and Chief Physician Officer for Roper St. Francis Healthcare in the Low Country of South Carolina. Thanks to all of our chamber members who join us here each week at the Pivot. And a big thank you to the Mount Pleasant Chamber's own Rebecca Imholtz for keeping us on track today. From all of us at the Mount Pleasant Chamber, thank you for joining us this week for the Pivot. Make it a great week.
Thank you so much.